Hi, I'm Dr. Ted Delbridge, Executive Director at MEMS. Each year around this time, we present for you updates to the protocols for Maryland's emergency medical services. It's surely not because the science of EMS changes only once a year or at this time of year. It's our effort to be efficient with your use of time. So in advance, thank you for the time you'll now spend to receive these important updates, and thank you for what you do each and every day.
Hello, and welcome to the 2022 Maryland EMS Protocol Update. I'm Dr. Tim Chismar, State EMS Medical Director. First, please allow me to offer my sincerest gratitude to all of our EMS clinicians who have cared for our patients, especially over the past 2 years. While many of our usual activities have been paused during the COVID-19 pandemic, the Protocol Review Committee has been hard at work. Based on the latest scientific evidence, I'm pleased to present you with a number of protocol additions, revisions, and even a few deletions. You should know our protocol changes come from a multidisciplinary team of EMTs, CRTs, paramedics, physicians, nurses, and other healthcare professionals. We are constantly reevaluating our protocols to provide you with the clearest, updated guidance on patient care. In a few minutes, you will hear about our new protocols from EMS clinicians and educators from across the state. But first, let me cover a few brief updates. Many of you are already familiar with the direct-to-triage protocol. This was approved by the EMS board during mid-2021 for immediate implementation. Most jurisdictions in the state have adopted this optional supplemental protocol. If you're unsure about your county or city status, please check with your leadership. The direct-to-triage protocol enables EMS clinicians to select patients who are stable for placement in queue for ED triage. Importantly, a verbal and written report should be given to the receiving triage or waiting room nurse. A second addition is the technique of left lateral uterine displacement for pregnant patients presenting with shock, hypoperfusion, or cardiac arrest. This concept is relatively straightforward and has been recommended by the American Heart Association. As the fetus grows larger over time, the uterus can compress the aorta and vena cava when a pregnant patient is in the supine position. This, in turn, can lead to a decrease in blood return to the heart and cause hypotension or low blood pressure. By applying continuous manual displacement of the uterus to the pregnant mother's left side, the pressure on the aorta and vena cava is relieved. For pregnant patients with the uterus palpable above the umbilicus, this allows for an increase in venous return and cardiac output. One final change I'll mention is actually a deletion. Based upon recent literature, including the Targeted Temperature Management 2 trial, otherwise called TTM2, the induced neuroprotective hypothermia protocol has been removed. In TTM2, investigators randomized 1,850 adult patients with coma after out-of-hospital cardiac arrest into 2 treatment arms. The first group received hypothermia to 33 degrees Celsius, followed by controlled rewarming, while the second group was treated by maintaining normothermia with early treatment of fever defined as 37.8 Celsius or greater. The primary outcome was death from any cause at 6 months. And at 6 months, 50% of the hypothermia group and 48% of the normothermia group had died. In short, there was no significant difference between the 2 groups. Importantly, there was also no difference in the degree of neurologic disability among the survivors in the 2 groups. The hypothermia group also experienced a greater incidence of arrhythmias. Targeted temperature management, particularly the prevention of fever, may still play a role later in the patient's hospital or ICU level care. However, for EMS, the evidence shows that we are most effective when we focus on high-quality CPR and defibrillation. Next, I would like to transition from the new protocols and touch on an important topic which may be overlooked, and that is patient refusals of treatment or transport. Generally speaking, non-transported patients are at higher risk for adverse outcomes. When you're confronted with these situations, please refer to the patient-initiated refusal of EMS protocol in the procedures section. This checklist will walk you through the steps. First, offer the patient or the potential patient an assessment and treatment. As you're speaking with the person, try to assess whether they have capacity to make medical decisions. Patients with capacity should be alert, oriented, and able to understand the risk and benefit of treatment and transport. If the patient is disoriented or lacks medical capacity, implied or emergency consent will apply, and the patient should be transported for further medical evaluation. We need to be cautious to use the lowest level of chemical sedation or physical restraint necessary to effect a safe transport for the patient. For patients with capacity, next you should evaluate for abnormal vital signs, high-risk injuries, or medical illnesses. If these are present, consult with the nearest base station so that the physician can speak with you and the patient about the decision. And finally, please be sure to document refusals thoroughly, including the refusal checklist. Be specific with your narrative. You should include details of what was said during the encounter. Include statements and quotes as much as possible. The no patient found call disposition should be reserved for cases in which there is really no person with a medical complaint or evident illness or injury found at the scene. If you're speaking with and assessing someone, you should document it. For more information on this important topic, please check out Who is a Patient in EMS in the MIMS Online Training Center. Notably, we should not be suggesting refusal of care or transport unless it is in the context of the pandemic triage protocol. This tool will remain available in EMEDS. It has undergone extensive study. When the checklist and decision support tool in EMEDS are used, the risk of subsequent hospitalization within 24 hours was very low, approximately 5%. In closing, I hope that you will enjoy this year's update. And again, thank you for taking your time to learn about the new 2022 Maryland Medical Protocols for EMS. I am grateful for your continued commitment to the best possible care for our patients in Maryland.
EMS clinicians are always there to help their fellow Marylanders with medical and trauma-based emergencies, but doing so can sometimes take a toll on us. When the job or a difficult call affects us, who helps the helper? Fortunately, there are resources available throughout our state to help support the professional and personal well-being of Maryland's EMS clinicians.
Hello, I'm Victor Wellshand, Director of Training for the International Critical Incident Stress Foundation, here with a few quick tips and reminders about stress and resilience. We all know that stress is a normal part of performing the important work of emergency services. Managing our stress reactions and building resilience helps us perform at our highest levels, stay healthy, and meet the challenges in our personal and professional lives head on. The good news is there are many things we can do to build resilience. Everyone is different, and there's no one way to do it. One of the most effective ways is to maintain our physical health through exercise, good nutrition, rest, and sleep. Knowing the warning signs of too much stress is also helpful. Supportive relationships are crucial to resilience, especially when under greater stress. Support is a core factor of resilience, so giving people in our lives time, energy, and caring is really important for our mental health. Doing things we enjoy is also a good way to balance the impact of stress. Hobbies, sports, and other activities that recharge our mental batteries help to balance our lives and make us feel good about ourselves, our relationships, and the work that we do. Relaxation and participation in activities such as yoga, meditation, and simply being outdoors are also good ways to build resilience.
Hello, my name is Courtney Shannon, and I am a paramedic lieutenant with Charles County Emergency Services. Camaraderie has always been a part of EMS. Although peer support has become a buzzword, the idea is fundamental to our profession. We have always had each other's backs and recommended services to one another. In recent years, many agencies have formed peer support teams and networks comprised of individuals who have basic training in behavioral health as it relates to working in this field. These colleagues take an often proactive, always confidential approach to recommending resources that understand who we are as clinicians. Sometimes they simply lend an empathetic ear for both on and off the job situations. Critical incident stress management can provide helpful intervention by talking through recent traumatic events. Like with peer support, CISM must be completely voluntary and should never be forced on anyone that doesn't feel comfortable talking. Confidentiality is of utmost importance to clinicians, and at times EAP services may provide the bridge to resources. To learn more about what your department has to offer, consider asking your chain of command. Again, if confidentiality is of utmost importance to you, consider calling the MEMS helpline at 1-800-648-3001. Callers to the MEMS number are connected with peer support and other resources in your area or surrounding jurisdictions. Should a member of your department be in crisis, please consider the National Suicide Prevention Hotline, 1-800-273-8255, or simply dial 211 and press 1. Suicide prevention resources are available 24/7 to anyone that is contemplating suicide. As EMS clinicians, we focus daily on our patients' needs and often overlook our own. Many resources are available throughout Maryland that can help you through the toughest times. Find out what is available in your area and ask for help. Remember, asking for help when you need it is a sign of strength, not weakness.
If you were at home and you or your child had a fever, how would you treat it? Odds are that acetaminophen, often referred to by the brand name Tylenol, would be high on your list of options. However, for EMS clinicians, ever since acetaminophen appeared in the Maryland formulary, it has only been authorized for treatment of mild to moderate pain, until now. Fever has not been an indication for its use in the out-of-hospital environment. This will change with the 2022 protocols. The other change that you will find in the use of acetaminophen is that the minimum age for its use has been lowered from 2 years of age to 3 months of age. Let's review the ALS and BLS pharmacology for acetaminophen, noting the changes in the 2022 protocols. Indications for administration of acetaminophen now includes patients 3 months of age and older with either mild to moderate discomfort, example 1 to 5 on the FACES scale, or fever documented by EMS as greater than or equal to 100.4 degrees Fahrenheit or 38 degrees Celsius. This is an important point. Acetaminophen should not be given for fever without obtaining an accurate temperature. Precautions for its use are administration of acetaminophen for mild to moderate pain doesn't eliminate the need to transport the patient to a facility capable of conducting a comprehensive evaluation of the cause of pain and providing appropriate definitive treatment. A maximum size of 5 ml or 6 ml syringe must be used to measure doses. For the smaller doses, a 3 ml syringe is acceptable. Syringes larger than 6 ml do not have fine enough demarcations to make accurate measurements. With the exception of the change in the minimum age for administration, the contraindications are the same as in the past versions of the protocols and include head injury, hypertension, administration of acetaminophen or medications containing acetaminophen within the previous 4 hours. Remember, many common cold preparations contain acetaminophen. Inability to swallow or take medications by mouth, respiratory distress, persistent vomiting, known or suspected liver disease, including patients suspected of current alcohol ingestion. Allergy to acetaminophen and patients less than 3 months of age. Acceptable preparation for administration remains unit dose preparation only. Specifically, clinicians may use either 160 milligrams in 5 ml liquid unit dose or 325 milligram pills or tablets for patients aged 13 years and older. Multi-dose bottles of liquid should not be used by EMS clinicians. Dosage of acetaminophen is based on age. Remember that for patients receiving less than a full unit dose of the liquid, 160 milligrams in 5 ml preparation, a 3, 5, or 6 ml syringe must be used to measure the dose. Patients 3 months of age may be administered 1.25 ml, that is 40 milligrams, of the 160 milligrams in 5 ml liquid preparation. Patients 4 to 11 months of age may receive 2.5 ml, 80 milligrams, of the 160 milligrams in 5 ml liquid preparation. Patients 12 to 23 months of age may be administered 3.75 mLs, 120 milligrams of the 160 milligrams in 5 mLs liquid preparation. Patients 2 to 4 years old may be administered 1 unit dose of 160 milligrams in 5 mLs liquid preparation. Patients 5 to 12 years old may be administered 2 unit doses of 160 milligrams in 5 mLs liquid, a total of 320 milligrams in 10 mLs. And patients 13 years old and above may be administered either 4 unit doses of 160 milligrams in 5 mLs liquid, a total dose of 640 milligrams in 20 mLs, or 2 325 milligram pills or tablets for a total of 650 milligrams. Pills or tablets may be administered with sips of water as tolerated by the patient. In summary, the 2022 protocols lower the minimum age for administration to 3 months of age and expand the use of acetaminophen to include the treatment of fever documented by the clinician as above, 100.4 degrees Fahrenheit or 38 degrees Celsius. You're treating an 8-month-old male patient whose mother advises has been sick with a cough, decreased oral intake, and a fever for several days. The patient is alert but cranky with capillary refill of 2 seconds, respiratory rate of 36, and a pulse of 122. His skin is flushed and hot to touch. You obtain an auxiliary temperature of 103 degrees Fahrenheit. The patient's mother tells you she ran out of liquid acetaminophen yesterday and has given the patient no medication in the last 12 hours. You decide to administer acetaminophen to the patient. What dose and route administration should you choose? A, 2.5 mLs, 80 milligrams of 160 milligrams in 5 mLs liquid unit dose, measured using a 3, 5, or 6 ml syringe. B, 160 milligrams in 5 ml liquid unit dose, administered using a 5 or 6 ml syringe. A, that's right. The correct dose for an 8-month-old patient is 2.5 mLs, 80 milligrams, which should be drawn up from a 160 milligrams in 5 ml unit dose using a 5 or 6 ml syringe. Good job.
Can you remember your last critically ill patient? Did you want to hurry up and get him to the ambulance so you could get to the hospital quickly? If so, we want to draw your attention to the new critically unstable patient protocol. The General Patient Care Protocol has always prioritized the identification and treatment of life-threatening conditions. The Critically Unstable Patient Protocol clarifies the criteria that should be used in determining which patients are critically unstable and identifies the immediate actions to be taken by clinicians on scene. In other words, we want you to resuscitate before you start transport. Why is this important? And why should we emphasize this now? Recent studies have identified that unstable patients are at a high risk for post-arrival respiratory or cardiac arrest, PARCA. One study found that the proportion of PARCA patients significantly decreased from 12.1% of out-of-hospital cardiac arrest to 5.8% when immediate life threats are addressed within the first few minutes of arrival on scene. The data indicated that most PARCA occurred within 13 minutes of EMS arrival. It's critical that we intervene early and definitively with unstable patients. As a part of general patient care, the goal of the initial assessment has been to identify and correct life-threatening problems as they are encountered. The 2022 General Patient Care Protocol expands the initial assessment instructions by first defining the criteria for a critically unstable patient, then referring clinicians to the critically unstable patient protocol. A critically unstable patient is any patient who is in extremis or has an imminent risk for deterioration to cardiac arrest. These patients include those with a new onset of altered mental status, airway compromise, acute respiratory distress, signs of poor perfusion, or any patient judged by the clinician to be in extremis or at risk for deterioration to cardiac arrest. When a critically unstable patient is identified, the initial assessment then directs the clinician to stop all movement of the patient, do not initiate transport, and proceed to the critically unstable patient protocol immediately. The critically unstable patient protocol applies to adults, those 18 years of age or older, who were identified in the initial assessment as being in extremis or at risk for deteriorating to cardiac arrest at any point during their care. BLS care under this protocol begins with a reminder to cease all efforts at patient movement until the treatments in this protocol are complete. Clinicians should then obtain a complete patient assessment including pulse oximetry, consider the need for additional resources if available including multiple ALS clinicians, control life-threatening external hemorrhage, manage the patient's airway and ventilation as indicated and tolerated. This may include BVM ventilation with or without an OPA or NPA. Treat hypoxia and respiratory distress aggressively. In addition to the BLS care already outlined, ALS clinicians should initiate end-tidal CO2 monitoring, obtain a 12-lead EKG if it is appropriate for the patient's condition, obtain vascular access and support perfusion with IV fluids and vasopressors as indicated, address any other life threats noted on the physical exam. Once these steps have been completed, clinicians should continue general patient care and refer to specific protocols for the patient's condition, including transport to an appropriate facility. You are dispatched to the home of an 80-year-old female patient whose family called 911 because she is having difficulty breathing. On arrival, you are met at the door by the patient's daughter, who advises you that her mother is normally alert and independent. She has a history of CHF and COPD, and today she is having difficulty breathing and is becoming agitated and confused. You approach the patient, and on your initial assessment, you find her in obvious severe respiratory distress with rapid labored breathing. Her skin is pale, cool, and clammy, and she appears restless and confused. Your next action should include A. Transfer the patient into your ambulance and begin rapid transport to the nearest ED. All care can be performed en route to the ED. B. Obtain a complete assessment, including pulse oximetry, consider the need for additional resources, and treat the patient's hypoxia and respiratory distress aggressively with nebulized medications and/or CPAP on scene prior to initiating transport. That's exactly what we want you to do under the critically unstable patient protocol. Good job.
Have you ever encountered a patient with an implanted ventricular assist device, VAD, in the field? Would you know how to assess and treat them if you did? Ventricular assist devices used to be rare, and patients using the devices were often confined to the hospital while awaiting a heart transplant. However, VADs are becoming more common, and their use is expanding from the initial bridge to transplant treatment to also being a long-term solution for patients unable to receive a heart transplant. Because VAD patients are often being discharged home to live relatively normal lives, the chances of them having an EMS encounter are much greater now than in the past. As EMS clinicians, we need to be prepared to assess and care for these patients. To this end, the 2022 protocols introduce a new ventricular assist device, VAD protocol. Let's take a look at this new protocol. VAD devices include left, right, and biventricular assist devices, which are collectively referred to as VADs. The left ventricular assist device, or LVAD, is the most common type. The new 2022 VAD protocol has both BLS and ALS components and applies to adult patients who have a VAD and have symptoms of cardiovascular compromise or are in cardiac arrest. The first thing you need to know before you even start your assessment is that most VAD patients will not have a palpable pulse or detectable systolic or diastolic blood pressure due to the continuous nature of the pump. Don't get worried. We will discuss ways to assess perfusion in VAD patients. The preferred method of assessing perfusion in VAD patients is through the use of a Doppler and a manual blood pressure cuff. However, few EMS agencies carry a Doppler device, In the absence of Doppler capability, automated blood pressure cuffs may obtain a mean arterial blood pressure, or MAP, in some patients. The normal range for MAP is between 60 and 90 millimeters of mercury. EMS clinicians should also be aware that some VAD devices do create an artificial pulse that is activated every 2 seconds. This is to decrease the chances of clot formation on the motor. As with any patient assessment, we're going to start by assessing the patient's level of consciousness and vital signs. Remember to obtain that MAP with your automated BP cuff, if possible, because you won't be able to obtain a pulse rate and systolic or diastolic blood pressure. Check for breathing and assist ventilations if necessary. Assess for perfusion, checking skin color, skin temperature, capillary refill, MAP, and mental status. If the patient has adequate blood flow or perfusion, the skin color should be warm, capillary refill less than 2 seconds, and the patient should be alert. If the patient has altered mental status but has other signs of adequate perfusion, assess for other causes of altered mental status unrelated to the VAD. Check blood glucose and refer to the hyperglycemia protocol if appropriate. If you're concerned about possible overdose, refer to the overdose poisoning protocol. For patients with abnormal perfusion, if your patient is unresponsive, not breathing, has delayed capillary refill, and you are unable to obtain a MAP, initiate CPR with a manual chest compressions and provide ventilations per the cardiac arrest protocol. Chest compressions must be manual using hands only, as automated chest compression devices may increase the risk of VAD dislodgement. VAD patients can be defibrillated or have an AED applied without any changes or adjustment to their VAD device. Assess for alarms which can be audible or reported by the patient or bystanders. Listen for the pump sounds if you are listening for humming or whirling sounds over the chest. Assess the VAD. Check the power and connections from the controller to the batteries and driveline. Contact the patient's VAD coordinator using the phone number on the device and/or the patient's VAD-trained companion, who will likely be your best source of information for the need to return to the patient's tertiary care center. Change the VAD batteries and/or the controller if indicated. If the VAD batteries require changing, change only one battery at a time. So to change out the battery on the HeartMate 3 or the HeartMate 2, there's 2 ways to do it. One would be to just depress the button here and pull out and change out the battery. You can check to make sure that the battery is fully charged. The other way to change out a battery is to disconnect. So you unscrew here and then you change out. Make sure that the half moons are lined up, and then you just depress and screw back on. Notice the alarm for the disconnected battery was going off at the same time. So if we had a controller fault and it says to change out the controller, this is the way that you want to do it. So it's easiest way is to turn it over and line up the 2. This is what you'll see once you unlock the actual door here. So it's in the lock position, now it's unlocked. Normally you won't see this button, you'll see this red one. So to change out the controller, what you want to do is you want to change out one of the batteries first. So disconnect one of the batteries and attach it. It's going to alarm. Then you're going to change out the drive line by depressing the button. And go ahead and silence. And now it's starting to run. See how there was little changeover? Then we want to change over the other battery. Silence. Line it up. Screw it on. Now the controller is changed. Now to turn it off, what you want to do is hold this battery button for 5 seconds until it goes off. And there you have changed the controller for the HeartMate 3. So this is the other style of VAD that you might see. This is the HeartWare model, and you can see a little bit different than the HeartMate 3. So to change out the battery on the HeartWare, it's fairly simple. So what you would do is you would rotate this clip right here, just really quick, pull it off, get a new battery, and then line up the arrow here with the red dot on top, and then just gently push on. Make sure that the pins inside don't get bent and you don't actually force it on. So in the event that the controller needed to be changed out, the easiest way to remember it is the 4 Ps. So it would be pacifier, power, pump, power. So I will demonstrate how to do that now. So in the event of a critical failure and you needed to change out the pump, remember the 4 Ps, it would be pacifier, power, pump, power. So this is the pacifier that is located usually on the spare controller. So you place it on the old controller. You change out one battery, place it on the new one, then you disconnect the drive line, put it in the new one, and disconnect the battery and place it on the new controller. If you did not have that pacifier on the device, that alarm would continue to go off until you found it or you placed it back on the device. This is what the pump for the HeartWare actually looks like inside. Always transport the patient's backup bag with batteries and a second controller with the patient. For VAD-related complications or suspected cardiac or respiratory conditions, transport the patient to the medical facility where the VAD was placed if the patient's clinical condition and time allow. For all other conditions, transport to the closest appropriate emergency department without manipulating the device. Whether you are an ALS or BLS clinician, whenever you are dealing with a VAD patient, there are a few important points to keep in mind. LVAD patients are preload dependent and afterload sensitive. VAD patients require anticoagulants and antiplatelet medications to prevent pump thrombosis so that they are at high risk for life-threatening bleeding. VAD patients have an increased risk of sepsis due to their driveline. Chest compressions must be manual, using hands only, because automated chest compression devices may increase the risk of VAD dislodgement. VAD patients can be cardioverted and defibrillated without any changes or adjustments to their VAD. The delivery of electricity by defibrillation or cardioversion will not affect the functioning of the device. Always ask the VAD patient if they have had any alarms and if their parameters are within their normal range. Early contact with the patient's VAD coordinator is encouraged. The patient's specific program should be contacted if possible, since they know the patient best. If that information is not available, phone numbers for the Maryland hospitals that implant VADs are included in the VAD protocol. You arrive to find a 65-year-old male patient who is unresponsive with skin that is cool to the touch. His family tells you that he suddenly passed out about 5 minutes ago and that he has a VAD. The alarms on the VAD are going off. You are not able to obtain a mean arterial pressure or MAP. He remains unresponsive to painful stimulus. His capillary refill is prolonged at 4 seconds. Your next step should be start CPR with an automated chest compression device. Start manual hands-only CPR. Correct. If the patient is unconscious, unresponsive, with signs of poor perfusion, the next step is manual hands-only CPR and further care according to the cardiac arrest protocol. Automated chest compression devices should not be used in VAD patients due to the risk of device dislodgement.